muito chamar o professor Christian Pavlovich. O professor Christian é professor da Johns Hopkins, de Urologia e Oncologia. É um grande prazer tê-lo aqui em Porto Alegre. Thanks so much, Christian, for coming. Vai falar sobre robotic surgery in uro-oncology, recent advancements and future developments.
Well, thank you for that great opening, Dr. Berger, and for the invitation, Dr. Bertet. I have been here once before at Moinos and with Johns Hopkins, and when I was invited a second time to come back, it was really exciting to me because I knew I would learn a little bit about where things had come. When I came in 2015, the robot was quite new, as Dr. Berger mentioned, and it sounds like the program, despite cost considerations, which we are all feeling now internationally, of course, has come along extremely well. I don't think we did any better with our first 120 cases oncologically at all at Hopkins. We were not the first to use the robot. I think we had robot number 17 in the US, and we came from an institution where either open surgery was the norm or where we were doing very advanced laparoscopy. So there was a resistance to move to a robot when you had technically skilled laparoscopists like Dr. Cabusi at our place or Dr. Gill at the time at Cleveland. But I think the world is moving robotic despite the costs. And I just want to touch on a few of what I think are the ways forward, what we will be seeing, rather than dwell on a whole lot of data, also for just time constraints. So robot-assisted surgery, or RAS, the FDA, our Food and Drug Administration, defines that as different types. It says there are different types of computer-assisted systems which can be used for preoperative planning, navigation, and to assist in procedures. So robotically assisted surgical devices are just one type of computer-assisted surgical system. Sometimes referred to just robotic surgery. RAS devices enable the surgeon to use the computer and software to control and move surgical instruments through one or more tiny incisions, etc., as we've learned. So that's our current term, robotics, which, as we all know, it's not really a robot doing the surgery. And worldwide, there is an increasing number of platforms that will be available. And I'm going to go over these a little bit over the next 15 minutes, starting with the Da Vinci, which is really the first one that's been marketed and that's been available, and until extremely recently was the only one. Now we have approval for the Senhance system, just recently approved, but that's not really being used urologically yet. The Da Vinci systems, they're calling these fourth generation systems. I saw from Dr. Berger's talk that there are now some Da Vinci XIs that are coming to Brazil. We've just made this change to the fourth generation at Johns Hopkins a few months ago. The company was pushing hard to have a platform where all of the instruments are interchangeable. So for example, we couldn't use the SI instruments, disposables, with the XI, as you'll see. So on the other hand, if you get a XI fourth generation system, which is the console and the tower, that will then be allowed to work with either the X patient cart, which looks just like the SI. It's just a little more slender. It's excellent for pelvic surgery, and it's less expensive than the XI. Or that can control the XI, which is the one that has the drop down and allows you to do more multi-quadrant surgery, which is better for nephroureterectomy. Or it adapts to their brand new, this was approved in America just this year, single port. Da Vinci had a single access system they were trying to develop, but they have scrapped that, and now they're calling it SP. So the idea is if you upgrade to this, although this looks just like the console you're using now, there's a lot of hardware in there that allows it to work with any one of the newer platforms, all of which have interchangeable instrumentation. What are the enhancements? Is this worth it, cost-wise, et cetera? I think that remains to be seen. I was very happy for pelvic surgery with an SI for 7 years. I think that the SI has limitations in certainly the retroperitoneum. I think it's got some limitations for nephroureterectomy and multi-quadrant surgery, but for anything pelvic, it's ideal, and it certainly is acceptable for a good robotic partial nephrectomy. We just got the X, which I've started using for prostate. You can see it's very similar. The arms are thinner. There's a little bit more depth that you can get, which again is not really needed for the pelvis typically. And then the XI really gives you kind of a much more greater field of operation. These are some of the other putative advancements, and you can see that what you can add to these, which is built in, instead of having to get at adapters for staplers and vessel sealers and the Firefly fluorescence imaging, they're all ready to go if you want to get those instruments, but those are expensive. I've just started using Firefly. We'll talk about that briefly. And some of the other things come as standard. Other things are unique to the XI, which is the drop-down platform, which is much more able to operate up and down, left and right on any patient. Our surgeons, general surgeons, prefer this for bariatric obesity surgery and other big multi-quadrant operations. You actually push a button and the thing almost deploys itself, and then you tell it where you're going to be operating and you point to the kidney, and the machine starts getting ready to access the kidney. And you even can get a bed that, if you want more Trendelenburg or less Trendelenburg, moves with the robot. We don't have that attachment, but that has been one of the historic limitations of robotics, is once you're fixed, nothing can move. Whereas with laparoscopic nephrectomy, I used to move the patients all the time. A little more T-Berg, a little more lateral, little rotation, etc. So now Da Vinci is marketing the SP single port system. I got to go to California to watch it, and I saw Dr. Kauk from the Cleveland Clinic do a cadaveric radical perineal prostatectomy with this. Now, it looked very good. It was bloodless because it was a cadaver, not because he was a great surgeon. It looks like this might be a feasible way to reintroduce perineal surgery for the prostate, if we feel that is an advance at all. But that's still an evolution, and it's still very difficult to do, because the single port system, as I'll show you, is kind of a long system, and the male perineum is not that long. So the camera and the robot almost has to be outside the body to be able to do the operation. So it's still a challenging thing. You know that the issues with single port has been that we're all used to the large workspace. It's very hard to get us as laparoscopists to start working in a very ergonomically congested space with many collisions. I tried this a few times and abandoned many years ago. And then even Da Vinci had troubles trying to integrate all of their instruments through the space and then trying to get them to cross. And this was sort of, really no one adopted this strange Da Vinci technology. So they realized this is what they needed. And so that's what they've been working on, and that's what just got accepted through the FDA. And they would love for us to buy this. Johns Hopkins now has a leasing program. This is somewhat unique, where we don't have to buy the $2 million robot. We can pay per case. That may be a model that they'll be exploring in other countries or in other centers in the US. We'll see. At some point, it feels like a win-win, but paying $1,000 per case for the use of the robot rather than a $2 million fee certainly might be an option to explore. So that's kind of their idea. They tout it as having a great amount of range of motion externally. You can flip from camera above to camera below, which is nice. But I don't know anyone who's used this device clinically yet. It, again, just was approved by the FDA a few months ago. So Da Vinci will be marketing this. I think that we're not quite ready to come up with what might be the ideal surgeries for this, but they've approached me because I do most of my surgeries extraperitoneally in small spaces already. This is reasonable technology for a small space where you don't need a bowel retractor or anything else. So we'll see. There's a company called Transenterix, which has come up with the Senhance system, which I would say, if you look at the innovations that Da Vinci made, wristed instrumentation, 3D optics, remote surgeon comfort, it's much easier than sitting and doing a laparoscopic standing up. And then of course the simulator, which Dr. Berger showed you, which has been great for teaching. What these guys have introduced now is haptic feedback, apparently, and eye movement camera control. So you look, and the robot goes where you look when you're on the console. This is what it looks like. It looks to me like there are 3 different towers. Each instrument can be moved a certain way. This you're familiar with. Their technology, it turns out, was not working, and their technology was not accepted by the FDA. So they bought an Italian company that had come up with some very interesting technology, and that's now their new platform. So if you see this Senhance platform, this is where it's coming from. Revo Eye is a company that I heard about by Dr. Kun Ra, who is a big laparoscopist in Korea. And this looks a lot like, this is basically a Da Vinci copycat. I don't think you could tell from the back of the room whether this is Da Vinci SI or X or Korean. This is a lot, I think, like Samsung and Apple or Hyundai and Honda. I mean, the ideal would be if this would be a lot cheaper, because the Korean FDA has allowed this to go through as non-inferior to Da Vinci. So if you can get this at half price, you can get a Hyundai at half price, and they work very well. So this might be a future for a country like Brazil. Of course, Da Vinci doesn't like this idea. That's why they made this new contract with Johns Hopkins that we lease them, but we're not allowed to use any other technology for 3 years. Another one is going to be the Sport, which is in development by Titan Medical in Canada, not FDA approved. And this is a single port, looks a lot like what Da Vinci is trying to come up with their SP. But Da Vinci got through the FDA, and Titan is still struggling. They have not filed for FDA as of this date. They're supposed to be trying to file in 2019. This, again, the idea would be cheaper than Intuitive. However, all they will have is a single port platform, which is going to be an expensive platform in general, I think. And then finally, there's some things in development that I don't really have a lot of insight on. It's very, very hush-hush, very quiet. You probably know that the initial work with the Da Vinci was done by the US Defense Department. So these things are very secretive. And we're not going to know much about, at least I don't, about the Medtronics. But I do know a little bit about Verb because some people came to interview me about sort of these topics in general. Verb is a new company. It's located on the Google campus in California, which can tell you how connected with technology it is. And just like in Dr. Berger's slide on the kind of the future of robotics, connectivity and data transfer and remote surgery are all what these companies are thinking about. We as surgeons aren't thinking about that as much because we still think about the patient next to us. But when the eagles are flying above us and looking down, what they see as the pillars of the future are robotics, better instruments, better visualization, connectivity, and data analytics and machine learning. And these just seems like platitudes, but this is from the Verb website as their pillars, and their motto is democratizing surgery, sort of like what Google did to the web. I mean, it's free, it's easy, everyone can access the power of the internet with a good search engine. Their sense is that with these technologies, they can basically spread these advancements throughout the world at reduced cost. And they have teamed up with Johnson & Johnson, with Ethicon, and other huge companies to try to bring this together. And they have a CEO and a research team on the Google campus. So maybe something will come from verbsurgical.com. Keep your eyes and your fingers posted. I think, in the interest of time, I will kind of slip ahead and let us get to some of our presentations that are going to look specifically. We're going to spend a lot of time on prostate, on kidney, etc. But I think these are the procedures where the robot has had the most impact, and I think will continue to. In terms of prostate, I think we all agree less blood loss, a better anastomosis, as you guys have studied as well, less pain, early return to work, and a better result cosmetically. And I think the anastomosis issue is, leads to not just shorter catheterization, but fewer contractures, and also long-term better continence. And so that is, I think, most important to the patient long-term. I think that looking back now, there's still a lot of discussion on is it safe to use this robot in advanced disease states, in high-risk disease, and a look back even at surgeries in the late 2000s, which seems long ago now, by Dr. Jim Hu. An analysis of the Medicare registry in the US showed actually fewer positive margins and less adjuvant treatment in intermediate and high-risk cases. So I think that suggests we're doing as good a job, if not better, with the better tools, and less adjuvant treatment is a huge cost savings. It implies less cancer recurrence, and it implies a lot less use of radiotherapy and hormonal therapy. Another technology I think that I found extremely helpful, which you will find helpful in retroperitoneal kidney and extraperitoneal prostate, anytime you have a confined space, is this air seal technology. I don't know, is this something you have seen or used here, anyone? It's I don't know the cost, but I think they sold it to us as the trocars are cheaper, so once you buy the box, overall, it seems less expensive, etc. I don't believe that, but that's what I'll say. The trocar goes in, it's a tri-lumen system, so it's infusing CO2, and then one of these lumens is assessing the pressure level. And if the pressure raises or lowers, it increases insufflation. So it maintains a constant pressure of 10, 15, or 20, whatever you set it at. So when your assistant is sucking and aspirating, and all of a sudden you lose your pneumoperitoneum or wherever you are working, this maintains it completely statically. So this is ideal for small spaces, for heavy patients, where just maintaining that space is important. I think this has been a big change. I have not had any issues with the space or with loss of insufflation during cases with these air seal systems. So it's very interesting and a helpful technology to consider. I'll kind of skip through radical because I think Lucas will talk about partial and radical nephrectomy, but I think we've seen huge advances. I want to show one thing that I just started using recently, and this is another technology to highlight that comes with the Da Vinci system if you want to use it. It's called Firefly technology, and it's essentially anesthesia will instill a fluorescent substance into the patient's veins while you're doing your partial nephrectomy. This is an example of a small renal mass that I did surgery on last week, lower pole, approximately 2.5 centimeters. What we did was we found that she had a main renal artery that branched, and I wanted to see if the lower pole was in fact feeding the lower pole. And you can see here that I basically put a clamp on one artery, injected the Firefly, and the upper pole fluoresced and the lower pole did not. So we had good ischemia in the area where we wanted to operate, and that was in fact selective arterial clamping, if you will. That allowed us to cut the tumor out and put about 4 sutures around it, kept together with 8 Hem-o-lok clips, and then afterwards we had extra Firefly agent, so we instilled it just to see if the area was getting reperfused after we took the clamp off about 20 minutes later, and sure enough the lower pole turned green, and everything was good except for the defect where the tumor was. So this is, again, expensive stuff, but can help in select cases, and it comes with the X and XI capabilities. I think this is a great platform for nephroureterectomy. You turn what used to be a huge incision into very small incisions, and in the end, according to a relatively recent multi-institutional series, certainly from a cancer standpoint, hitting all the marks of quality. Where I think the robot has kind of hit a limit might be cystectomy. And this is a list of the different institutions that are studying this. There's an ongoing NIH randomized trial, some other trials going on, but the really big published ones come from Sloan Kettering, which was a randomized trial of open versus robotic cystectomy. Their primary outcome was complications, and there was a similar rate of complications between the two. That trial was closed early because they realized its utility. They would never show a difference between open and robotic, given the rates of complications that they were accruing in both. However, the robotic group did have less blood loss, however, significantly longer OR time. They updated this in 2018 to look at oncologic outcomes, and there was no difference in oncologic outcomes of any kind overall. However, the interesting thing, there was an increase in metastatic sites in the open cases, but an increase in intralocal and abdominal sites in the cystectomy patients. So they're concerned that what we're doing somehow is contributing the peritoneum, pneumoperitoneum, to seeding of sites or to dissemination in the peritoneum. Given that, on the other hand, there were more metastases later on found in the open cases, I'm not sure how much of that is true. I know their program is also relatively new, but it's something to watch. For now, I would say they're equivalent, but obviously cystectomy is much more costly when done in a robotic situation. So I think the jury is still out if it's worth using that for this. So in conclusion, I think there's little question that in specific cases, robot-assisted surgery is safer and more effective. There are really fascinating new technologies and new robots coming onto the market finally. The question really is, will competition reduce costs? Each new advance comes at an added financial cost, often direct cost. And I think we need cost-benefit analyses, but these rarely easily translate into healthcare policy. That's always done at a level beyond urology, unfortunately. We're lucky to have a fellow who's interested in health policy, who has spent time in the government, and maybe he will become a spokesman for urology, because as it stands, our public health system has no surgeons in Washington, D.C. on the Medicare panels. So we need someone like that as an advocate. Anyway, thank you, and I will let the other folks take over. Appreciate it.